chair the first session, I call upon Dr. Panir Selvam, Dr. G. Vijay Kumar, and Dr. Sunil Gupta.
Good morning to everybody, and thank you, Dr. Shanmugam and Dr. Panneerselvam sir, for putting me as a chairperson along with you. It's a great honor to me. And then we have today, there's a small change in the program. The first talk will be delivered by Dr. Anuj Maheshwari on hyperglycemic crisis in diabetes, how to sail smooth. You have a slide? Introductory slide? Dr. Anuj. Yeah, Dr. Anuj Maheshwari needs no introduction. He is such a wonderful human being. First of all, encourages everybody. He takes along, his greatest ability is that he takes along everybody with him. And he is such a big man, both nationally, internationally, recognized personality, but still is so humble. That's the greatness of Anuj. And let us congratulate Dr. Anuj Maheshwari for being elected as President of National RSSDA. So thank you, congratulations to you, sir. And then we wish you many more accolades in future as well. And we heartily welcome on behalf of all the Tamil Nadu RSSDA to Chennai, and then hope you'll be visiting us more during your presidentship. I think we need to take our chapter also to great heights. Dr. Anuj Maheshwari, please, sir.
Thank you, Chairperson, and my good friend Dr. G. Vijay Kumar for the kind words about me. First of all, thanks to all members of the RSSDI Tamil Nadu for getting me elected as President, RSSDI. I am really grateful that I shall be taking over the charge from my one of the beloved senior and mentor, Dr. Vijay Viswanathan. So he is sitting with me and it's really a pleasure for me. And now coming over to the topic. I shall be talking about the hyperglycemic crisis in diabetes, how to sail smooth. Hyperglycemic crisis in diabetes usually we identify as hyperosmolar hyperglycemic states in type 2 diabetes, very commonly seen, and diabetic ketoacidosis is seen more commonly in type 1 diabetes. Hyperosmolar hyperglycemic state is also known as hyperosmolar non-ketotic coma. It is less common than diabetic ketoacidosis, usually seen in the older individual. Mortality remains 5 to 20%, which is much higher than diabetes ketoacidosis. Often present with altered level of the consciousness due to hyperosmolar state. And ketoacidosis is usually not seen in this situation. Glucose levels are much higher in hyperosmolar hyperglycemic state than ketoacidosis. It's actually identified by the hyperglycemia, hyperosmolality and dehydration, but no ketosis. Frequent precipitants could be the stressors, infection, infarction, failure of the insulin or insulin emission, ischemia, intoxication, maybe alcohol or some medication. Renal failure is very common situation to precipitate in hyperglycemic. Inducing medications also give rise to this. So all these are the stressors or precipitants for this situation, and it is arising due to the increase in secretion of the glucagon, cortisol, epinephrine, which are the anti-insulin hormone. So we find that two regulatory hormones which works against this stressor situation, which are the insulin and glucagon, and their balance usually keep the hyperglycemia to be checked most of the time. Glucose is ingested during a meal and stimulate the release of insulin from beta cells of the pancreas, and we know that insulin works for the disposition of the glucose which is being received from the meal. Overall net reduction in effective circulation, insulin with a net increase in counter-regulatory hormone like epinephrine, cortisol, glucagon, as I said that all these are the anti-insulin hormones. So there is a all phenomena of the balance between the insulin and anti-insulin hormone, which decides whether the patient will come up into the hyperglycemia or not. So hyperglycemia is mostly because of the impaired peripheral utilization in the peripheral tissues, which happens after the meal intake of the glucose. And another one, during the fasting state, we see that increased gluconeogenesis becomes the reason for hyperglycemia. And if it is associated with the insulin deficiency, which is more predominantly seen in diabetic ketoacidosis as compared to the hyperosmolar hyperglycemic states, we see that it is actually giving rise to the hyperglycemia crisis because insulin is not there to handle this crisis. This medical emergency when we talk about the diabetic ketoacidosis because of the absence of insulin, mostly seen in type 1 diabetes but can also be present in type 2 situation in certain, especially in the pregnancy. Common in younger patients like which are lesser than 65 years of the age and women are more commonly seen. Mortality is 5%. This is good thing. As far as the non-ketotic coma is concerned, that is having a heavy mortality as compared to the decay. So it is actually a life-threatening state that results from a relative or absolute deficiency of insulin. Insulin deficiency results in loss of uptake of the glucose by peripheral glucose transport, so it comes into the blood and causes the hyperglycemia. This deficiency activates hormone-dependent lipase, which leads to the increased lipolysis. This leads to conversion of the triglyceride to free fatty acids and cholesterol. So fatty acids are converted to acetyl coenzyme, which is shuttled into the Krebs cycle, which is insulin dependent. But on the other hand, if insulin is not there, then it is the HMP shunt which works and ketone bodies are formed, including the dihydrobutyrate and acetoacetate. So what are the precipitating factors for this? Of course, inadequate insulin or absence of insulin, non-compliance, forget insulin dose could be the common reason. New onset diabetes which is not identified and not treated, acute illness, infection, cerebrovascular accident, MI, acute pancreatitis, medication, clozapine or olanzapine, cocaine, lithium, terbutaline are the common reasons for precipitation of the diabetic ketoacidosis. So what happens normally? Normally we see whenever the hyperglycemia is there, pancreas gets activated, it releases insulin which goes to the liver, controls the hepatic glucose output. And on the other hand, the blood is also being serving the source of the glucose to the peripheral tissues, and muscles are utilizing the glucose from the blood. And by balance of these two activities, blood glucose is being maintained between 80 to 120 milligram per deciliter. But what happens when we are having a lack of insulin? Once we are having a lack of insulin, glucagon takes the driving seat. And once the glucagon is more, it induces more glucose output from the liver. Usually liver is the organ which keeps us alive when we are not eating anything, especially in the night. It supplies the glucose in the night time or in the fasting state. But once the glucagon takes the driving seat, it supplies the glucose all the time, whether we are fasting or not fasting, and blood glucose rises like anything. At the other hand, it reduces the insulin-stimulated glucose utilization in the peripheral tissues because insulin is not there. So these two activities are actually working in diabetic ketoacidosis. And last but not the least, the free fatty acids which are moving from the peripheral tissues or fat to the liver, they becomes the responsible for further increasing the situation, making it more and more severe. At the same time, it becomes that in the absence of insulin, HMP shunts gets activated and more ketones are formed. So inadequate insulin leads to the energy stores from the fat and muscles to be broken down into fatty acids and amino acids, and these precursors are transported to the liver for the conversion to glucose and ketone. So once the insulin is not there, then fats and then proteins or amino acids are utilized for the energy needs of the body. So this is the pathogenesis what we commonly see, that absolute insulin deficiency, relative insulin deficiency, and in between we see that counter-regulatory hormones are getting increased and which are sharing their part of causing hyperglycemia with both the state, whether it's absolute insulin deficiency or relative insulin deficiency. So when we see these diabetic ketoacidosis, it is identified by the polyuria, polydipsia, dehydration, electrolyte depletion, eventual renal hyperperfusion. Ketones can be identified by the acidosis, compensatory respiratory alkalosis, hypotension and stroke. So once we see that diabetic ketoacidosis and its clinical course, which is seen as a worst case scenario, a normally doing patient doing well suddenly comes into the association of the precipitating events or precipitating causes and starts having more of the urine passing, polydipsia and dehydration, followed by the anorexia, nausea, vomiting, abdominal pain. Many a times it is associated with the small respiration, juicy fruit breaths, and altered consciousness comes up and patient ends up with the cardiovascular collapse and finally goes into coma and death. So this is the situation what we can happen and how we can really avoid it by the smooth sailing. Factors which are leading to the impairment of the CNS function usually in our patients are the acidosis, hypertension and hyperosmolality. If we can really avoid them or we can treat them well, we can avoid the patient in going into the unconscious state. Diagnostic triad of the diabetic ketoacidosis, hyperglycemia, anion gap and hyper level of the ketones or ketosis. The anion gap represents the presence of unmeasured anions, and it can be calculated by subtracting the all cations from the all available anions. And once we see that organic acids like acetoacetate and beta-hydroxybutyrate decrease the bicarbonate, which is a biological buffer, are not measured in the gap, therefore this gap further increases. So the treatment actually needs to the IV insulin, IV fluids, electrolyte replacement, carbohydrate replacement if the glucose level comes down to 250 or less than that. Administration of the bicarbonate for acidosis is usually not recommended, but if the pH comes below 7, then it is needed. So treatment for the diabetic ketoacidosis is more important to understand. Don't let an elevated potassium to fool you, because many of the time this is a quite a thing which is not to be believed once what is being seen there. What happens in the situation of the acidosis? Hydrogen ion shifts into the cells to be buffered by the intracellular buffers. Potassium shifts out of the cells in exchange. So it comes outside and it gives an appearance of the hyperpotassemia or hyperkalemia. Consequently, the serum potassium may be elevated despite total body potassium is depleted. So it is a situation where we understand that potassium level is quite normal or it is on the higher side, but actually patient is requiring the potassium supplementation. But always is to be kept, remember, it should not be started till the patient start passing the urine. So treatment with insulin causes potassium to shift back into the cells, and serum potassium may drop like a rock during the therapy. So this is the situation which is to be handled very intelligently, and we should keep mind while making this. Treatment of the diabetic ketoacidosis is also depending upon how do we keep a watch on the anion gap. Therefore, during the management of the diabetic ketoacidosis, don't watch the ketones, watch the gap, because acetone is produced during the normal regeneration of the bicarbonate and is detected by most serum ketone assays. Therefore, the serum ketones normally increase during recovery from diabetic ketoacidosis. So these are the diagnostic criteria for diabetic ketoacidosis and hyperosmolar or hyperglycemic states. I am not going into the details, are much known to all of you. Obviously, the hyperosmolar states is not associated with the ketosis. Diabetic ketoacidosis is associated, and more important is to understand the pH. If the pH is less than 7, we have to give the bicarbonate. If the pH is between 7 to 7.25 or up to 7.3, this is the ketoacidosis, depending upon the severity status. Less than 7, severe; 7 to 7.24, moderate; and more than that is the mild. And hyperosmolar coma is the situation where pH is always more than 7.3. So these are the three. I am not going into the detail of this slide. It's a very busy slide, but 4 things are to be must understand by seeing that IV fluids are the most important pillars for the management. Insulin is the second one, and potassium is the third one, and last but not the least, assess the need of the bicarbonate. If the pH is less than 7, we need to give it, otherwise we don't need to give it. As far as the hyperosmolar non-ketotic coma, it is again a life-threatening metabolic disorder of extreme hyperglycemia without ketosis. Common precipitating events are the almost same: myocardial infarction, stroke, sepsis. Potentially deadly mortality may exceed 30 to 50%. Non-ketotic coma pathogenesis lying with the hyperglycemia, polyuria, volume depletion, hemoconcentration, and what we see more commonly, hyperviscosity and increased risk of the thrombosis in patient with the hyperosmolar non-ketotic coma. Disturbed mentation, neurological signs are there in the form of the seizures, motor abnormalities in the form of the flaccidity, depressed reflexes, tremor or fasciculation. Ultimately, if we don't give any treatment, patient dies with coma and death. Similar to the treatment, as far as the treatment of the hyperosmolar non-ketotic coma, again, it is not very much different with the diabetic ketoacidosis. We need to correct the hydration, volume correction with the normal saline. Replacement of the electrolytes is needed if IV insulin, and diagnosis and treatment of the underlying cause is the most important thing. So finally, the take-home message is, in addition to the absolute or relative deficiency of the insulin, net increase in counter-regulatory hormones like epinephrine, cortisol, glucagon becomes the important reason for the hyperglycemic crisis in patients of diabetes. Hyperosmolar coma or hyperosmolar state mostly occurs in type 2 diabetes patient, while decay is more commonly in type 1 diabetes. Correction of volume depletion always remains a priority. Correction of the dehydration should always be taken on the first-hand treatment. Many a times the mild problem gets corrected even during that period only. During treatment, potassium level and ketone bodies should always be taken with a pinch of salt. So whenever you are managing any patient with hyperglycemic crisis, always keep a watch on the potassium level. Don't be confused with the level of ketones, and always keep an eye on the anion gap. That is the most important reflector of the improvement of the patient. Thank you for your kind listening. So at the end, I would definitely say that we are looking forward to adopt 1,000 villages across the country. This picture you can see that we have adopted in Noida with idea President Peter Schwartz, one village. And I will also request the Tamil Nadu chapter to identify such villages. In next 2-3 years, we shall be trying to reach this target, which has been much earlier given to us, to complete the 1,000 villages to be adopted by RSSTI and work there so that we can avoid the diabetes dissemination in those places. Because always remember that India, 69% population lives in the villages. Until unless we will not focus to that population, we cannot stop the diabetes in country. We cannot stop our country to becoming the diabetes capital. This is my say. Thank you very much.
Thank you, Dr. Anuj. And you have given an excellent topic where basics have been very well explained in a simple fashion. That's most important thing, including the precipitating factor and as well as insulin deficiency. And also, I'm so happy that you told about the simple thing about anion gap, which is not taken into consideration generally in practice, and that is one of the things that we can look into the prognosis of the disease. Thank you very much for your, and then also thank you for giving us an opportunity to adopt some villages as well. Thank you.
Thank you. Thank you.
And Dr. Anuj has to leave immediately, so that any queries from the audience, if you can just, yeah.
Sir, I'm Dr. Aditya, sir.
Yeah.
So my doubt is decay in special population like in CKD with GFR less than 30. We have one patient in ICU. So your pearls in it, sir, regarding management guidelines. Decay in CKD.
If EGFR is less than 30, admitted the DKA, what is the policy he is trying to ask?
Yeah, of course, if a patient is having the CKD, we need to correct. One is the hydration correction to be done, looking over to the status of the kidney, depending upon the input and output status and what amount of the fluid is already being accumulated in the body. Second thing, insulin again becomes the most important tool for the correction even in CKD. We use usually the short-acting insulin. In the DK, always we try to correct with the short-acting insulin. And CKD also, it is recommended to correct it with the short-acting insulin. Many a times we see that in CKD, the diabetic ketoacidosis may be induced by the starvation also. So starvation-induced diabetic ketoacidosis should always be handled with very carefully, because in CKD, patient runs into the hypoglycemia most of the time whenever the medications are given, and they are utilizing most of the most of the glucose, and patient is not left with. So in such situation, these are the additional challenges when we are treating any patient of the CKD, and we should take care of them whenever we are treating DK kind of the situation in a CKD patient. What very commonly type 1 diabetes patient go into the CKD, and we need to find them, and it is a great challenge when type 1 diabetes patient is in the renal failure. And even in type 2 diabetes situation also, as I already said in my talk, that pregnancy, CKD are those situations where we can find diabetic ketoacidosis. And now the SGLT2 inhibitors has been another cause for the association of this with euglycemic ketosis. Without hyperglycemia, you get the ketone bodies in the blood when you are using the SGLT2 inhibitor. This is the almost same picture. What you get into the CKD, what you get in the starvation ketosis, what you get in the SGLT2 induced euglycemic ketosis. So they should be handled with, and fluid supplementation is the best thing there. But once you have CKD, again it is a challenge how much fluid is to be given. Very given very cautiously and very carefully.
The next topic, technique in de-escalation of the anti-hyperglycemic therapy. Of course, de-escalation is now keep on happening after the arrival of newer molecules. And Dr. Rajiv Kovil is going to give the talk on de-escalation. Over to Dr. Rajiv Kovil.
Thank you so much. Thank you, the organizing committee of TRAC. I'm going to talk about de-escalation of anti-hyperglycemic therapy, and there needs to be a de-escalation of a lot of talks also, because we are bombarded with knowledge nowadays. Whenever we listen to any talks on diabetes and anti-hyperglycemic agents, we only talk about escalation. So that there were strategies given to us that you go on chasing an HbA1c below 6, go like cowboys, chase below 6.5. Then they told us that you have to look at cardiovascular risk. Then they told us that you have to look at nephrology risk. Then we looked at technology coming in. So there are a lot of strategies which are put into place. Like UKPDS told us that if you control them very aggressively, initial on, you may not get benefit on atherosclerosis. The post-trial data said that later on you will get benefits. Similarly, there's no significant data on de-escalation of therapy. There's always a lot of data on escalation of therapy. And I believe that for clinicians it's very important to realize where do we de-escalate therapy and the importance it has. So there are a few recommendations, and I'm going to go into that. How can we use polypharmacy? Probably where do we de-escalate therapy? And I'm sorry that my junior has done the slide, so there are some spelling mistakes, so it's not my spellings. But when do we first de-escalate therapy? Obviously hypoglycemia. And in any person at high risk, whether he's on a secretagogue, when his EGFR is low, when he has liver failure other than maybe Hep B causes insulin resistance, so his sugars are usually high. People with more than 3 hypoglycemic events per week, earlier this used to be called as brittle diabetes, or people with very low life expectancy also. And again, at every consultation we need to see that whether we can de-escalate therapy even in a long-standing diabetic, especially in the elderly population. In patients receiving GLP-1 therapy, again establish close monitoring of biliary symptoms. That is also if suppose you get any kind of symptoms related to biliary disease, gallstone disease, we should de-escalate that therapy. Patients obviously with a history of any acute pancreatitis, we will de-escalate and remove the GLP-1. Patients with recurrent UTI, recurrent GTI, we again will de-escalate from the SGLT2s. And again, whenever we are on secretagogues, we would love to keep reducing the dosages of the secretagogues. And a lot of data, especially post-hoc from dulaglutide, has said that the award group of studies, that when you give GLP-1 for a very long time, the alpha cell suppression is so good that probably the dosages of the secretagogues go down also. When do we de-escalate antihypertensive? In case of a syncope, in case of Stoke-Adams, in case of hypotension. Urate, uric acid lowering therapy, when the uric acid remains 6 for life. Lipid lowering, if suppose patients have elevated enzymes, or in case of myopathy. Insulin, we are used to escalation and escalation. We know that insulin can cause a lot of weight gain, MDIs can cause, sometimes even cause pedal edema, can cause even sometimes failure as well. So again, when we have to de-escalate from an MDI, suppose the patient is elderly, what we will do is probably start reducing the prandial insulin. We may continue the basal insulin and try to achieve a fasting between 80 to 130. If the patient is on premixed insulin, maybe 2 to 3 times a day, it is switched to basal insulin, maybe only at 40 to 50% of the dose, and maintain a fasting plasma glucose of 80 to 130. Metformin we will usually continue, and we have a lot of insulinotropic agents which do not cause hypoglycemia. So we can de-escalate with the help of a lot of these agents today. A lot of fixed dose combinations can be used for de-escalation also. We have today fixed dose combination of basal insulin, GLP-1, we have Idec-Lira as well as Iglar-Lixi. What's the rationale of this combination? Basal insulin provides a good control over the fasting glucose. GLP-1 acts on the postprandial. So this is a good way of reducing MDI therapy. And the advantages, actually we have seen in the Dual 7 study on Idec-Lira, that Idec-Lira once a day was almost equivalent to multiple dosages of insulin or basal bolus therapy in patients with type 2 diabetes. They also had improved glycemic control when we de-escalate, had improvement in weight, and again less treatment burden. Therefore, the mean daily injection went down, and also when we de-escalate, the glucose variability goes down. That's what we see when we de-escalate from an MDI to Idec-Lira. Many a time you see that the glycemic variability has gone down. Dr. Maheshwari was speaking about chronic kidney disease, and there's a need for de-escalation in chronic kidney disease because renal gluconeogenesis is something which we forgot. Hepatic glucogenesis only we remember, and that the liver produces and liver gives out glucose, but there is renal gluconeogenesis which goes down with chronic kidney disease, and that's why most of our patients with chronic kidney disease suffer hypoglycemia either in the night or early mornings. So again, the previous guidelines said that we could use shorter acting agents, shorter acting secretagogues like repaglinide, DPP4. The newer guidelines suggest that we could use a lot of insulinotropic drug like the SGLT2, and with the flow study coming in, also the injectable semaglutide as and when it comes in. The GLP-1 is very safe to be using in patients with a eGFR of up to 15. SGLT2 should be started for every CKD patient. That's not more than 60, but less than 60. In advanced CKD, we should always think about insulin, but GLP-1 but SGLT2 inhibitors would decrease the dose of insulin. What are the various factors that would help in de-escalation? The various factors that would help in de-escalation of therapy is again severe weight loss. So whether it's a GLP-1 or whether it's a lifestyle-based therapy, severe weight loss can help in de-escalation of our anti-hyperglycemic agents. Bariatric surgery now we know works through the GLP-1 pathway itself, that bariatric surgeries can help in de-escalation of therapy. And there are a lot of app-based monitoring today where there are health coaches and they chase the patient with a health coach, and you are able to de-escalate therapy. Now, this is not hyperglycemia, it's not hyperglycemia. The indication for absolute de-escalation is hypoglycemia. Patients who have a very short lifespan, if suppose somebody has widespread cancer, we would de-escalate therapy. Patients in the ICU, and we know that patient is having a poor outcome or a poor prognosis, we will de-escalate therapy. patients on ventilator for a limited life, we'll de-escalate therapy. So de-escalation of therapy is extremely important, and also important is de-escalation in a newly diagnosed diabetic. Somebody who comes with severe hyperglycemia, you may put them on probably insulin or basal bolus insulin, but as soon as the hyperglycemia and the osmotic symptoms and the weight loss has stabilized, we'll then convert them to either a basal or maybe a insunotropic agent. And that de-escalation is not only in newly diagnosed patient, but it needs to keep on going on. And even de-escalation in antihypertensive therapy. The only place that we should not de-escalate if the patient is statin tolerant, that should always continue. But otherwise, antihyperglycemic as well as antihypertensives needs to be de-escalated. I have saved the organizers 5 minutes, so I'm open to any questions if there are anything for de-escalation.
Lucid presentation and very short presentation.
Thank you.
In fact, me and Dr. Pannisalam were discussing 15 minutes not may be sufficient. We did it in 10 minutes. And it's very important to know that, suppose somebody is, nowadays we are with a lot of FDCs, fixed drug combination. What is your opinion on that? Because it is very difficult for fixed drug combination to de-escalate the treatment when the people get into hypoglycemia. How do you suggest that?
I think it is, because Google is there, we are protected, because we need to always Google many of the FDCs which come in. And today, we have only FDCs related to one particular segment, that is anti-hyperglycemic. But moving forward, we will have an anti-hyperglycemic and an antihypertensive together, which has already been launched. We have a statin and an SGLT2 coming in. So there's going to be a lot of, because which is actually happening today, because we put one brand of SGLT2, he goes to the cardiologist, he puts another brand, he goes to the nephrologist, he puts another brand. So I think the FDC is causing more commotions and problems to patients, chemists, retailers and us.
Especially after the arrival of all your SGLT inhibitor and gliptin, we are in the position to de-escalate sulfonylurea as well as insulin. Once you de-escalate sulfonylurea or insulin, glycemic variability is going to come down, and hypoglycemic episodes are also going to come down. And persistent good control is possible after the arrival of these newer molecules.
Absolutely.
And new monitoring system also.
Absolutely.
So the only two agents causing hypoglycemia is insulin and sulfonylurea. All other agents along with metformin will not cause sharp hypoglycemia. So with this newer agent, we can de-escalate sulfonylurea as well as insulin.
Surely, absolutely.
Of course, sulfonylurea, metformin and DPP4 inhibitor or SGLT inhibitor combination, they are difficult to de-escalate. We have to remove sulfonylurea from the combination.
Rajiv, easy question, don't worry. How do you de-escalate somebody from basal bolus to premixed? We're going to have a beautiful lecture on premixed insulin, but how do you de-escalate? Nobody wants to take 4 times.
So type 2, I would calculate the basal insulin, what is required, and in the premixed insulin, whatever is given, the basal insulin component remains the same to start off. And then we would up titrate. But it all depends on why the patient is on basal bolus. If he's just for a short term and then we are de-escalating, then it's fine. Then the total basal component needs to be taken into consideration, and then
so you calculate the basal dose.
Yes. So whenever we convert, whether it's an intermediate acting insulin or a basal, the total basal remains the same.
No, to the extension Dr. Vijay Vishwanathan has asked, somebody is on basal bolus. The second best seems to be the 2 doses of co-formulation. Do you agree with that? The studies also indicate the same actually.
Yes, but I agree with that. And if the patient can use a GLP-1, it works very, very well. And if the patient, it all depends on why the basal bolus is there. If the basal bolus is there for glycemic control, then it's better the patient is on basal bolus. It's for a short term, for a surgery or a crisis situation, then we can always de-escalate.
Yeah, as you said that, no, the one which is introduced, lexacendrate with basal insulin glargine, I think both of them, I think they'll have an advantage of taking care of both fasting, and lexacendrate will take care of the postprandial.
Absolutely. Yeah. Absolutely. The dual 7 data is very much, very, very strong on that.
Thank you, Rajiv.
Thank you so much.
Yeah,
Over to you, Anjana.
Rajiv, one question.
Yeah.
Sir, in one of the presentation you said hyperglycemia with asthmatic symptoms
No.
is an indication. When patient develop asthmatic symptom, invariably they will develop hyperglycemia. And how we can de-escalate at that time?
That was a spelling error, sir. That's what that I corrected it.
Hypoglycemia.
It's hypoglycemia. I'm happy you are observing the slides.
Because,
Thank you so much.
Many people will go with a wrong impression.
Yes. Thank you so much.
When the blood sugar is very high and certain situation, we use a basal bolus, then trying to bring down 2 or 3 injections. Do you think that doing a C-peptide analysis or an insulin assay, or will it help in identifying, at least get to know what is the beta cell reserve of the patient, so that will the patient be changed over, or the insulin injections and dosage can be reduced and put them on oral drugs which can act?
No, sir.
Because sometimes we start insulin, we keep on continuing insulin without knowing that whether the patient has got insulin reserve or not. Patient continues for a long time.
So,
do you think that doing a
C-peptide for initiating or de-escalating is a wrong strategy? We cannot be using
No, when you have a doubt whether the patient has got an
it's
insulin
only
reserve.
for diagnostic purposes only. After that, sir, C-peptide loses.
I understand, Rajiv, but when a question whether the patient, sometimes today a lot of people come and ask, at the middle of the diabetes, they come and ask us, what type of diabetes do I fit into? There also we can use, and whether...
Yeah, I agree, but it's stimulated C-peptide, which is either post-glucagon or proper mixed meal, which we do not get. So fasting C-peptide cannot be taken as a standard marker for insulin dependency.
Sir, only one small question, sir. When we initially have newly diagnosed patient, initially we want to have the preference, like ideally, to have insulin so that we can protect the beta cell function. So when we start insulin initially, so that we can have legacy effect later, when can we switch off on these patients to the de-escalate to the like triple drug combination or that thing? In your experience, when can we do?
So yes, true, because the longer you give insulin, the better remission. So there is also a honeymoon phase in type 2 diabetes. It's not there in literature, but there is a honeymoon phase. So once you are treating the glucotoxicity, you will go down to oral medication. So the longer you give insulin in newly diagnosed, the remission will be better and better and better.
Thank you, sir.
Thank you so much.
Rajiv. Though it's a small and crisp and informative lecture, you have generated so much of discussion.
Thank you so much. Thank you.
Thank you.
Speak, Dr. by Anjana, lessons from ICMR INDIAB study. Dr. Anjana is known to all of us. She is from Dr. Mohan's Diabetes Center, and she is in practice for more than 15 years. She is actively involved not only in clinical practice as well as research and studies also. She is the primary author of this INDIAB study, ICMR INDIAB study. The United Nations also recognized ICMR for this study, and recently they have given some award also. So congratulations to Anjana and for her contribution to the diabetes field. Over to Dr. Anjana.
The ICMR INDIAB study is a mammoth study, actually, representing the whole country. And then it also has given us a lot of information, how to address the people, how to, the amount of metabolic disorder that we have, and the impending, future diabetics in the form of pre-diabetes. The amount of information that we're able to get, including dyslipidemias, the typical Indian phenotype dyslipidemia is represented in ICMR INDIAB study. And there are so many, this is a mammoth study representing, if I remember right, it is by the urban, semi-urban as well as rural. Combined it has been that. See, this is one of the beautiful part of it actually. All the 3 states are rural, suburban and urban. Everything is there. I think we are really longing to wait to hear to Dr. Anjana. Please go ahead.
So, thank you everyone. I'm back. So let me just get back to where I was. I'm talking, thank you sir for that little introduction on the INDIAB study. So, yes, this is a mammoth study which has been funded by Government of India for the first time to produce data for this country state by state by state on metabolic NCDs. Now, let's move on to the diabetes data. And why I wanted to show you this is because I have some new data for Tamil Nadu. So this was the data that was presented in INDIAB 17. What is the overall prevalence of diabetes in this country? It's 11.4%. It's double in urban areas compared to rural areas. So it's 16 in urban and 8.9 in rural. But this is the interesting and new part. You can't see the top, but this is state of Tamil Nadu. Now in Tamil Nadu, government gave us permission to do 2 time points. We went back after the initial survey that contributed to the INDIAB 17 first national data. We went back 10 years later to look at differences over a 10-year period. Now shown in red bars are urban areas, green bars are the rural areas, and of course the yellow is the overall. So look at the prevalence of diabetes in Tamil Nadu, urban. It went from 13.7% to 27.2%. Huge increases in urban Tamil Nadu. But what about rural? Again, it went from 7.8 to 17.7. So huge increases in increase in the prevalence of diabetes in Tamil Nadu. Please don't take photographs of these. These are unpublished data. Next, if we look at pre-diabetes, so the pre-diabetes numbers in the country overall are actually larger than the diabetes numbers. So we know that people with pre-diabetes convert into diabetes. So what does that tell us? The diabetes burden will keep increasing. The feeding into diabetes will keep happening. So these numbers, the 2 things here are, number 1, the prevalence number is higher than diabetes, it's 15. Second is urban and rural is equalized. In diabetes, we saw differences. Here it's equalized. So what does that mean? The prevalence in rural areas is very high. Now 70% of India lives in rural areas. So every percentage increase there translates to millions more in terms of absolute number of people or burden of diabetes on individual and healthcare systems. So this is the national problem that we have. Now let's go to Tamil Nadu. Again, look at these numbers. You'll see that pre-diabetes has gone from 9.8 to almost 20% prevalence of pre-diabetes. Rural India 7 to 18.7. It's just, hiking. It's you can't even catch it. That's the way it's moved over the last 10 years. And please remember that Tamil Nadu is one of the developed states in this country. Even here, you're seeing galloping and escalating numbers of diabetes. Imagine states that are not yet there. You're going to see tripling, quadruples, all of these. Now what about obesity? National numbers are given here, urban almost 40%, and this is BMI, generalized obesity, and 23. Tamil Nadu is given here. 35.7, 50% of urban people living in Tamil Nadu have generalized obesity. In rural areas, it's not far behind. It went from 20 to almost 40%. Now, what about abdominal obesity? National numbers had already reached 50% when we published this. Now, where is Tamil Nadu? Today, we're at 63.9, 64% prevalence of abdominal obesity in Tamil Nadu. These numbers are really high and really scary. If you look at hypertension, the overall number is about 35% higher in urban and rural. Tamil Nadu data, 33% went to 41, and rural has also reached 45% in the current time that we are. Dyslipidemia, national numbers are 24%. This is hypercholesterolemia. Tamil Nadu numbers are way above the average. 40% of people in urban areas and almost 38 to 40% in rural areas have a high cholesterol level. Triglyceride, of course, is an Asian Indian phenotype. It's high all over the country, not just in Tamil Nadu, but again, small increases that you can see. And in HDL cholesterol, you can see that it was high then, high now. This is part of the Asian Indian phenotype, the high triglyceride and the cholesterol. But look at what the other things are: diabetes, pre-diabetes, obesity, hypertension. What the story we're saying is that over the last 10 years in the state of Tamil Nadu, we're seeing like doubling of our numbers that are happening, increasing the burden all over the state. Now, this is the publication that declared the number of millions of people with all these metabolic parameters in the country. Currently, we have 101 million people with diabetes, 136 million with pre-diabetes. Hypertension is at 315 million. Our highest number, of course, is 350 million with abdominal obesity. So these are the numbers. Now, we have so much of all these. What about control? A, B, C control. Do we have people with good glycemic blood pressure and lipid control? Let's look at A1C. Overall, we have 35% people who have their A1C less than 7% at target, and all the others that we have seen are still not reached their glycemic levels. Now, what about Tamil Nadu? So here's what I wanted to talk about. There's two things that have happened. One, there's an increase in the numbers, so doubling. But look at the level of control. We actually started off 10 years ago, we started off with something like 35, 37% with good control. That has actually decreased. So what's happening? We don't really know. We're talking so much about awareness. So many programs have come in. Government has gotten involved. Makkale Thedi Maruthuvam. So many things are happening. But ultimately, are we giving good outcomes to our patients? It looks like over the last 10 years, we've actually decreased in our ability to deliver good care. And this is definitely of concern. Is this because new people have come and not reached providers? Are we just diagnosing and not giving people proper care? Is our follow-up lacking? Is the health system getting overburdened? We don't know. There are lots of questions to be answered right now, but the fact remains that in this country, we still have a lot of, there's 8 minutes more, right? Did someone ring the bell? Okay, sorry, I got, yeah, okay. So there's still a lot to be done in terms of our level of control. Now, this is SMBG. So how much of SMBG are we doing? Well, suffice to say that we're not doing enough. We only, even those on insulin, only 30 to 40% are doing any SMBG. And for all type 2 diabetes, it's less than 20%. Tamil Nadu numbers are looking very bad in terms of what we're doing. Then we're doing better than before. We're doing more SMBGs than we're doing before, more awareness, but still overall numbers are not yet there. Blood pressure control, about 50% of people are reaching the target of 140/90. In Tamil Nadu, again, the story is like this. Our numbers have come down from before. 10 years ago, we had 53% of people in urban under good control. Today, it's 30%. So we really need, these are waking up numbers. You know, we're talking so much, we're doing so much. Do we have proof that there is outcome? Are we doing good things the right way? These are questions we have yet to answer. These are again national cholesterol numbers for total cholesterol, triglyceride and LDL, the number of meeting the various targets as shown there. And in Tamil Nadu, the story remains that for all the parameters I've shown so far, whether it is A1C, whether it is blood pressure, or any of the cholesterol numbers, we're not reaching targets. As a matter of fact, there are people slipping through the net. Now, what about lifestyle factors? We'll start with carbohydrates, which is, I think, the most important thing. So this paper is currently being submitted to Nature Medicine. And what we show is what is the carbohydrate intake of this country. This is a color-coded map. White areas are rice, we know that, south and the east. The brownish areas are wheat, and that's like the central and northern regions. And the very small reddish kind of areas are the millet consumption. So it's no big new thing to say that 70% of everything that the Asian Indian eats is carbohydrate anywhere in the country. But look at the vegetarian, non-vegetarianism. Overall, 74% of the country reports being non-vegetarian, right? And in Tamil Nadu, that is 98%. 98% of people living in Tamil Nadu report being non-vegetarian. So what will you think immediately? Oh, Tamil Nadu doesn't have a protein deficiency. We're all good with the protein. But the problem with this reporting is as follows, okay? This doesn't stand in Poratasi. This doesn't stand on Thursdays, Saturdays, Tuesdays, Mondays, you know, all kinds of rules like this are there. And then there are ovo-vegetarian, lacto-vegetarian, eating only fish, eating don't eat fish, eat so, all these kinds of rules. Eat, you know, eat in the morning, don't eat in the evening, fasting, that time they won't eat, only, so all kinds of confusion. So because of this, while overall if you ask them to eat non-vegetarian food, they'll say yes. But are they getting enough protein? No. right? So protein deficiency remains in this country whether or not you eat non-vegetarian food. That's point one. Now coming back to our carbohydrate about rice and wheat. So we looked in to show whether or not risk of rice increases the risk of diabetes. What are we showing here? This is rice. Eating a large amount of rice every day, defined as 171 gram per day, gives you about 1.8 times more times of having risk of diabetes. So rice, refined rice is risk. Now let's go to wheat. Okay, wheat is whole grain, everybody eat chapati. We keep telling our patients that, it's good to control your diabetes. And many times, I'm sure all of you have faced, patient will say, doctor, I'm eating chapati, but my sugar is not under control. Yes, we face this is the reason. Okay, this is the wheat consumption and risk of diabetes. It's actually higher than rice consumption. It's 2.2 odds as compared to 1.8 odds. Now, why is this happening? Refined grain versus whole grain. The problem is it's not refined grain versus whole grain. It's refined grain versus even more refined grain. Right? Because the wheat that we are getting is not whole milled wheat. The wheat that we are eating is chakki fresh atta. Small particle size, high GI, okay, made with all kinds of accompaniments and eaten in the most unhealthy way with a lot of ghee and oil. All this makes it very high GI, and at the end of the day, eating the wheat, you lose the benefit of that. You may as well eat brown rice or something, because eating that chapati is really not helping you here. Wheat or rice, equally, the sugars are going quite high. Now, what about physical activity? We know that physical activity is a failed subject in India. Right? How many people meet recommendation? Very small number. How many people are inactive? Urban areas is 75% national numbers and 56% in rural areas. So whoever thinks that people are actively walking behind bullocks in rural areas, wake up, doesn't happen anymore. Rural India has become very much sedentary. These are national numbers. Mechanization has come, industrialization has come, people are sitting inside machines, they are not moving anymore. Now, what about Tamil Nadu? Pretty much the same as the rest of the country. There's one thing in which India is completely homogeneous. It's not climate, it's not food, it's not language, it's not dressing, it's not culture, it's not anything. It is physical inactivity. Wherever you go across the country, distinction above 70%. And it will be the same everywhere. Doesn't matter which state you're in, we have homogeneity in this country in one issue, physical inactivity. Right, so who meets the guidelines, which have actually changed, but these are the older guidelines. 8% of males and 2.4% of females meet our guidelines, so better not talk too much about that. So what happens if you are physically inactive? These are activity levels both overall and in Tamil Nadu state. The more inactive you are, the more diabetes you have, and there is enough proof for that. New kid on the block, migration. Especially in COVID, this became very important. So people can move from urban to rural area. People went from rural to urban area. It went in all ways. So we have four groups of people. People who always stayed in urban, people who always stayed in rural. Those are the people who didn't migrate. Then you have people moving from rural to urban, urban to rural. So we looked at all four and looked at metabolic risk. So what are we showing here? We are showing that the highest metabolic risk is not for the person who was born and brought up and stayed forever in urban areas. It is for the person who moved from a rural to an urban area. That person is at highest risk because they grew up with a certain environment, a certain risk, and then they changed that. What and all changed? The food pattern changed, stress level changed, activity level changed, all of this changed, his environment completely changed, and that increased his risk for all of these metabolic NCDs. Duration of migration, the more the duration of migration, the more the risk for all of these metabolic NCDs. So here's a kind of heat map of the various problems. On the x-axis on top, you have various things, A1C, BP, etc., and it's color-coded, state-wise, given here. The worst thing is the red is physical activity. Okay, I already told you that. Complete distinction, completely homogeneous. The other two are the Asian Indian phenotype thingies, the HDL and the triglyceride. So it is not a very good picture as of now. INDIAB has not done repeat surveys except in Tamil Nadu and Arunachal Pradesh. The repeat survey has showed that the picture is getting worse. Our level of control is not great. So what do we do about it? Well, this is data from the CURES study, which was done in Chennai, to know how can we prevent diabetes? What can we do to control? This data shows us that just two risk factors, diet and physical activity, can at least theoretically control about 50% of all diabetes. This is more for women than it is for men. Okay, but theoretically, leave everything else that we talked about, pollution, environment, migration, this, that. Just diet and physical activity, 50% can be controlled. So let's look at diet. The macronutrient recommendations from INDIAB state the following. We all know that 70%, 80% depends where you are. Overall, it's 62% of Indian diet has carbohydrate. Protein is low. We spoke about that. It's 12%. Total fat is at 25% and fiber is at 3.5%. So what do you need to either prevent or control diabetes? Very simple. Make the carbohydrate 50%. Don't have to do very low carbohydrate diet, fat diet, get rid of carbohydrate. Don't do all that. All you have to do is decrease the carbohydrate amount to about 50% of everything you eat. What do you do with the carbohydrate you reduce? Do not, make it go into fat. Don't increase the fat intake. Fat intake is fine. Replace with protein. So repeat, decrease carbohydrate, increase protein, increase fiber. If these three things happen, carbohydrate 50, protein 20, fat is at 25, fiber is at 6, you're all good for metabolic health. The last one is on physical activity. Just to note that the World Health Organization and all organizations now recommend not 150 but 300 minutes of moderate to vigorous intensity activity per day. MVPA means if you walk for 1 hour, you should walk at 5 to 6 kilometers. That is the speed at which, not the 1 to 2 kilometer jaywalking on the beach, not that, but 5 to 6 kilometers per hour is your intensity for all categories except in pregnant women, where 150 is still the norm. For older adults in geriatric age group, multi-component activities are given for various other reasons, and sedentary behavior has become the new smoking. So what you're doing right now, sitting, cut the sitting time to less than about 6 hours per day, and that improves metabolic health. So I'd like to conclude by saying that we have a lot of lessons learned. The prevalence of diabetes is high. It's continuing to grow. All of our metabolic NCDs are not under very good control. There's a lot to do, but let's just take 2 things, diet and physical activity. Start with that, work with everything else, and we hope we will be able to change the NCD story in our country. Thank you very much.
Thank you, Ranjana. And as I suggested earlier, this is, I think, eye-opener for many of us actually. In fact, if you look into that urban areas, we have been thinking that we are doing a better care, but we are lacking behind rural areas.
Sir,
actually.
I rechecked that data like about 20 times before I decided, because I was so shocked actually.
It is supposed to have, we are supposed to give in the urban areas a better care.
That's what we think,
But I think one of the things, I think also what I find from the reason is that I think more physical activity, less abdominal obesity, yes, and more mobility. And I think the awareness and the treatment, I think treatment is also improved even in the rural areas. Probably that could be the reason.
That has happened. Awareness and government, especially in Tamil Nadu, is picking up screening, large-scale screening programs, I think. The other thing, sir, is COVID. The one we did first is pre-COVID. After COVID, we definitely know that there have been huge increases.
Yes, Anjana, good talk, but it's very difficult to take up the data that India is a homogeneous point in physical inactivity. I think nowadays the recent things we are seeing, the parks, everywhere people are more aware of, more health conscious, people are using a lot of smartwatches, started walking, footsteps are monitored. I really, have a really not willing to take up the data what you are given, and all the things, the diet, exercise controls diabetes. There's a lot of already evidence, and we are all convinced we are already doing in the practice itself. Diet restriction and physical activity is the cornerstone of diabetes management. So what new thing you want to say in this study? Because what are all we do in the practice, years and the last decades, we are focusing mainly on the lifestyle, and really gives good results. And by controlling the diet and exercise, you said we can control diabetes. It's already known. And
but not implemented. That's a problem.
So that's the thing I'm trying to say.
Kumar, who is implementing? Everybody is, all the healthcare people gathered here are implementing.
Dr. Parandaman,
we are in the part of implementation.
You want to ask a question?
Anjana, one question. It's a very obvious question. Why is it so high in Tamil Nadu? as
So-
compared to the other states?
So
What's
we
the
don't know
hypothesis?
about the other states. We've only done the repeat surveys in Tamil Nadu and Arunachal Pradesh. In Arunachal Pradesh also, there's exactly the same,
Same
doubling.
kind of-
Yeah. We don't know from the other states. We haven't really looked at it. I'm so sorry, sir, but I disagree with you completely, because knowledge is one thing, behavior is one thing, something totally different. The smartwatches and things that you're talking about are a very small percentage of the population, right? People know about it, yes, I agree. People are trying to move towards it, yes, I agree, but we haven't reached there. Who can afford all these smartwatches, ring watches, these watches? Who can afford all that? We're talking about the general population here of India, and that population we have not reached. We have not, and that is what the data is showing, and that is absolutely new.
Dr. Parandaman, last question from
Yes.
you. Last
Madam,
question.
it's
Yes,
a
sir.
real great presentation, a lot of new information, so what really very happy about the study. But my concern is, in Tamil Nadu, is the amount of food or the type of food? Because we take as usual anybody like a North Indian, whether the amount is more or the type of food, like now cookies, biscuits and all, our people used to take more. Is it that contributes for the diabetes? Is there anything like that?
Sir, it's both. It's both are there. So the amounts haven't actually drastically gone down, but the amount of density of food has increased. So the amount of rice and things, but the amount of density, very high, rich food is what is being consumed. So it's both. Binge eating, lots of correct. Very correct. Very correct.
Last question, please.
Yes.
Yeah.
Thank you for providing me the time. Anjana, I'm very thankful to you for the eye opener. I think we also have to include something called mind opener. Right? I just have to put forward three things, because this last 10 years, there is a steep change in certain things. One is the gadgets and attributing it to the sedentary behavior.
Yes.
And people have not learned to break the sedentary behavior.
Correct.
Though, as sir said, there is an increase in the behavior, awareness. everything towards more physical activity, but they have not learned to break
Change
the
the behavior.
sedentariness.
Correct.
Exactly.
That's the point.
And one more thing is, there are a lot of false messages against
Correct.
scientific promotions,
Correct.
what we do with our patients, exactly in WhatsApp.
Very
For the
correct.
last 10 years, that has been the increase, and people have started believing those unscientific
Very
but
correct.
scientifically appearing
Yeah.
things
Yeah,
which are
you are
being
right.
passed
Actually, in the last year,
to the
last 2
public.
years,
Yes.
it is WhatsApp message comes, mangoes will decrease the sugar.
Yes.
That's what's happening.
Yes,
It's
sir.
very bad
And there
that-
are false promises
Correct.
being given by the alternative medicine people
I agree.
with regards to remission and the diet patterns to be followed.
I agree,
Even the
madam.
millets, I think they have been given with all wrong concepts, including keto, and people have been so very well this thing to take whatever is convenient to them from each one,
Very
and
correct.
following the very bad diet instead of going towards a promoting
Which is
line.
why we need the scientific evidence. Even though
Exactly.
we need to know what exactly to do and follow it.
Yes, I think having known all these facts, I think as physicians, we'll have to attend to these things also.
Yes. Agree,
Thank you, sir.
Thank you for your contribution.
you.
Thank you. As she pointed out also, there is obesity rate is comparatively high when compared to diabetes and hypertension. Obesity is high. Thank you, Dr. Anjana. We wholeheartedly thank you on behalf of all of us, because you are the real lady who did the study.
Thank you, sirs. Now it's time for presentation of mementos. We request Dr. Vijay Kumar to present the memento to Dr. Anjana. We request Dr. Panni Selvam to present a memento to Dr. Rajiv Koval.